preparing live stream. And I'll share my screen. We can start. Julia, we can start the session.
Okay. One. All right, we're starting.
Yes.
All right. Okay. Welcome everyone to the second day of the fourth annual edition of Metaverse Safety Week, a pivotal event exploring the intersection of AI and emerging realities in the immersive healthcare domain. I'm Julia Scott and chair of this track. I'm thrilled to guide our discussions today. So I serve as the medical council lead for XRSI, and that's backed by the research I do at Santa Clara University in the Brain and Memory Care Lab within the Bioengineering Department, where we're using neurotechnology and other immersive technologies to design interventions for neurobehavioral health. I've also co-founded Gambit Labs, which is doing work along those lines of brain-computer interfaces for games and VR platforms. So today we stand at the forefront of a healthcare revolution where AI and immersive technologies merge to redefine patient care. We are deeply grateful to the National Health Service England and the Medical XR Advisory Council for co-organizing today's discussion and for the pivotal roles in today's discussion spotlighting AI's transformative power in healthcare. Our goal today is to delve into the emerging field of medical XR and immersive healthcare within AI-driven environments. We'll engage in in-depth discussions about the ethical implications, privacy concerns, and patient autonomy in this new frontier. We will also address the challenges of ensuring patient safety and the potential biases in AI algorithms as they apply to medical diagnostics and treatment. These discussions aim to navigate the intersection of healthcare and AI, ensuring that advancements respect and uphold human rights and medical ethics. To coordinate today's session, several members of the program committee will be assisting me online. For some of the key roles I'd like to highlight are the moderators of the discussions, Richard Price and Divya Chander, and our timekeeper, Michael Iwashima. We also have the representatives from Swarm AI, David Baltoxi. So just to give some guidance to how we will use our time today, and thank you first for giving your time today to be part of this discussion. Overall, this will be about 3.5 hours. We'll have 2 breaks, 5-minute breaks, and then a longer 20-minute meal break. We'll start with opening remarks, followed by 3 testimonies from key stakeholders, about 5 minutes each. In each of the discussions on the 2 separate we'll have 2 thematic discussions on subtopics, each followed by intelligence gathering Q&A session, where contributors and observers can collectively shape our conclusions. All the collective input will be used to compile a post-roundtable report with appropriate attributions to be published after Metaverse Safety Week, which concludes and before the year ends. So as we start and we share our ideas, let's keep in mind some ground rules. Please keep your microphone muted unless speaking. Please use the virtual hand raising feature to contribute. Also, keep your comments concise and within the allocated time. We'll always maintain respect and professionalism in our discussions. And at any given time, please use the chat feature to post related resources or side comments. So you are encouraged to be on video, especially when you're delivering your remarks. A special thank you to our lead sponsor, Meta, for sponsoring the event for the third year in a row and to ensure it remains accessible and free to participate. Many thanks to AstraZeneca for sponsoring today's track as well. AstraZeneca has created its own fair charter for AI usage in order to protect employees and patients and ensure data use is ethical. Having experimented and derived value from XR internally with use cases for human skills and experiential learning for employees, the next potential frontier is exploring the intersection of these technologies, understanding how they can provide patient-centric experiences which accelerate diagnosis and evidence-based health outcomes. The programming committee deserves commendation for curating an impactful agenda and our community partners for their active contributions and observations. Before I turn this over to the co-host, let me remind you that Metaverse Safety Week is a 5-day affair, and we still have 3 more insightful days ahead of us. Today, as our Medical XR and Immersive Healthcare, co-organized by NHS and XRSI. Tomorrow, December 12th, is a Child Safety and Children's Rights, co-organized by UNICEF and XRSI Child Safety Initiative. On Thursday, December 13th, the focus is on cybersecurity and data protection, co-organized by the Global Privacy Assembly and XRSI. Lastly, on the 5th day, December 14th, is Global Policy and Regulations, co-organized by the Global Privacy Assembly and XRSI. So now I'll hand it over to our co-host, Richard Price from NHS England.
Thank you, Julia, and hello, friends and peers. I am absolutely delighted to be here today and to have been invited to co-chair today's healthcare session for Metaverse Safety Week. I'm Richard. I'm the Global Health Workforce Education Specialist at the United Kingdom National Health Service. So much of my work has involved preparing the global health workforce for a digital future through digital education, through learning technologies, and that, of course, includes immersive technologies like XR. So I have the huge honour of working with peers, with colleagues, and now people I'm proud to say are friends around the world in their digital education journey. And throughout my career, I've been supporting that delivery of education and training with health and care organisations across the UK, with the World Health Organization, and with governments around the world. So if you're not familiar with the NHS, it's the universal healthcare provision funded by taxation and free at the point of access to all patients. So approximately 60 million people across the United Kingdom. The NHS is also amongst the largest employers in the world, with more than 1.5 million employees involved in the care of patients. And that's across primary care and secondary care. Now, keeping those employees trained and educated falls to our team in NHS England. And increasingly, that means using new and emerging technologies to train that workforce and make sure that people can learn just in time, in real time, to be able to deliver the best possible care to our patients. The technology enhanced learning team where I work is investing heavily in XR and the Metaverse to educate that health workforce. And we do that all the way through from pre-education through to undergraduate and postgraduate education and all the way into the workforce. So it's a huge undertaking, and we have very traditional ways of doing that through e-learning and other techniques and tools. But increasingly, we're using XR to be able to deliver that education and training. And now we first started working with the XR Safety Initiative as we began to recognise some of the safety challenges around using immersive technologies. And with education, we're obviously concerned about privacy within XR from an education point of view, but those concerns increase exponentially as we start to bring XR into the delivery of healthcare. So as XR starts to intersect with diagnoses, with treatment. Now, AI alongside that offers so many possibilities, as we all know, with tools like ChatGPT and other tools that are out there. But imagine what can be done with those rich sources of data that are being generated from an XR environment and the impact that potentially has around patient safety, around privacy within this healthcare environment, and that trust between the healthcare professional and the patient. And that's where our discussion is going to start today. So as we proceed with our discussion around immersive healthcare and AI, we're looking to find a balance between innovation and shared responsibility. The key objectives from today's session are to anticipate the impact of AI, of how patients interact with providers and health workers are trained. And secondly, we're going to be discussing strategies to bolster patient agency and mitigate the risk of patient data in regard to those AI tools that I've described. So lastly, I'd like to thank individuals and representing organisations who are here today, who are actively contributing and observing. Thank you to SCU Macula Centre, Neuro Rehab VR, Papaline Therapeutics, NHS England ourselves, Cognition, and Yale Paediatrics. A full list of those community partners and contributors is available on the Metaverse Safety Week website, metaversesafetyweek.org. So I'm going to hand back to Julia now to start our initial keynote speaker.
Hello. So in this next segment, we're going to hear from a few key contributors, starting with Dr. Walter Greenleaf. So Dr. Walter Greenleaf is a behavioral neuroscientist and medical technology developer working at Stanford University. He has over three decades of experience in this field and brings a unique perspective. He has designed and developed numerous clinical systems, including products in the fields of surgical simulation, 3D medical visualization, telerehabilitation, clinical informatics, and many other areas. As a scientist, Dr. Greenleaf's focus has been on age-related changes in cognition, mood, and behavior. His early research was on age-related changes in the neuroendocrine system and the effects on human behavior. Since then, he has served as director of the Mind Division, Stanford Center for Longevity, as well as working with the Media X program as a visiting scholar with the Virtual Human Interaction Lab. As a medical technology developer, Dr. Greenleaf's focus is on virtual reality and digital health technology to treat a variety of neurobehavioral conditions. He supports the advance of the field broadly by serving as a VR technology and neuroscience advisor to several early-stage medical product companies. He has also served as scientific advisor to the U.S. Public Health Service and NSF, NIH, and NASA, as well as the Department of Education. So his perspective on where the field has been and where it is going comes from this wealth of experience. Today, he will share how his vision of the intersecting technologies of biosensing, spatial computing, and artificial intelligence will shape the healthcare practices and our mindsets about healthcare. Dr. Greenleaf, the floor is yours.
Well, thank you, Julia. Such a wonderful introduction, although I'm going to start sending out much shorter bios when people ask for them, because I'd rather focus my time on talking about what I'm passionate about, what everybody on this panel is passionate about, and the concerns that we have about this technology and how to make sure as it moves forward into our healthcare ecosystem and has a profound impact that we shape things the right way. I have the task of giving an overview of a very, very broad emerging field with a lot of moving parts. So I will jump right into doing that now. Please understand as you hear my presentation that I'm compressing what normally would be probably a 5-hour talk down into about 8 or 9 minutes. But I will be happy to answer questions offline if people would like to get in touch with me by email. Happy to follow up. But let me jump in by sharing my screen and providing you with my overview of this emerging arena. Okay, I will try and give an overview of the overarching context of how immersive technologies are impacting the healthcare ecosystem and where we are today. Talk very briefly about the research foundation, which is significant for these technologies and often misinterpreted or misunderstood. Many people don't realize that we have had decades worth of underlying research supporting what we're doing now. I'd like to talk very briefly about the neuroscience of why emerging technologies such as XR are having such a profound impact and why we should pay attention to them. give some example of the spectrum of applications, some specific examples, and then hopefully spend significant time talking about the concerns and the challenges. And I will follow up with a conclusion that of my optimism regarding the impact of this technology and how it will make a profound difference in helping us reach underserved populations, provide healthcare in a strong and powerful way, and addressing some previously difficult to solve problems by leveraging immersive technologies. Okay. One of the reasons I'm so passionate about this, and many of my colleagues are, is that we're very conscious that there's a crisis looming. Just as one example, in the US, our population has doubled since the 1970s, but family sizes has shrunk dramatically. If we do the math, in 10 or 15 years, we know that we will not have enough informal caregivers to support an aging population with the proportionate of neurodegenerative diseases, mobility impairment, stroke, Alzheimer's, chronic pain, supporting an aging population as we live into our 80s and 90s and longer is going to be an economic challenge, and I think could possibly be more impactful than the concerns we have with conflict or climate change right now. Fortunately, we have some time to address this. Healthcare demand is evolving. We have new problems to address, but immersive technologies will have a big difference in this area. And I'll give some very specific examples. But we have to leverage technology to address this looming problem. And the sooner we get moving, the better. In that regard, I work with several of the groups at Stanford that are focused on leveraging immersive technologies for healthcare. But I think more importantly, there's a large number of emerging technology groups that are focused on leveraging technology, bringing it out into the healthcare ecosystem and moving things forward. And this is extremely exciting. I'll give some examples of where there is traction. As you know, we're in the middle of a digital health revolution with the patient becoming the center of care as opposed to the clinic or the hospital. We're leveraging wearable sensors, machine learning, and focusing on telemedicine applications where appropriate. In the last 15 years, every medical device has moved from the analog world to the digital world. And this is allowing us to do some very profound things. And with the evolution of wearable sensors that many people are using to keep track of their health, to understand their sleep, their exercise, and other parameters of healthcare, we now have a large amount of data that will accompany what is going on with immersive technologies to allow us to come up with a more precision medical approach. We're leveraging the power of population analytics, precision medicine, to do so much more than we've ever been able to do before. But there are some concerns. And it's not just the physical data about our health that we're collecting information on. We're now able to do a better job of objectively measuring both cognitive and emotional state. We can use passive data from our smartphones as a way of coming up with a brain health biomarker, for example, or voice analytics as a biomarker for anxiety and depression. We can capture facial expressions in response to a challenge and use that as a biomarker or objective way of measuring an emotional state. And we can evaluate cognitive function in a more functional way using immersive systems. This gives us great power, but it also provides some challenges. The other aspect of what's going on right now that's going to have an impact on all these issues is the changing digital healthcare landscape. The tech titans, Apple, Samsung, Google, groups like Amazon and Walmart, et cetera, are moving into healthcare on the clinical side, not just on the health and wellness side. We're seeing a shifting regulatory landscape that is supporting telemedicine, and we're having a focus on mental health. These shifting trends in business will enable us to leverage them to come up with better applications within healthcare. One thing that we all should keep in mind is as the technology companies drive deeper into providing better consumer electronics that are responsive to our emotional state, our cognitive state, they will be leveraging affective computing to try and interpret using eye gaze, wearable sensor data, movement data, geospatial location data to better understand us and interpret this information to improve the user experience using technology. This is fantastic in the sense that we can leverage this movement by the tech titans into understanding personalized experiences, personalized effective measurements. We can use this for healthcare, especially in the fields of psychiatry and psychology, but it does present us with some challenges and concerns. We should anticipate that over the next 15 years, we will see the emergence of more immersive technologies, more action at this in terms of using systems that are not just fully immersive, but we'll see more mixed reality and augmented reality applications. And these will be applied to ways of indexing our attention, our alertness, and our mood as a ways of improving our ways of interacting with each other, with the built environment, and with communications and transportation technologies. Again, fantastic for those who would like to move these sensing and effective analytic technologies into the fields of psychiatry and psychology, but challenging when it comes to protecting information and making sure that we move into this arena in a safe manner. We're seeing the movement of the digital twin paradigm that's being used in managing factories and cities into the healthcare arena. With this movement, capturing a digital twin of ourselves is the concern about protecting that information. The digital twin paradigm for healthcare requires us to collect a lot of very personal information. Keeping this information private and safe and using it appropriately is the challenge that we're facing. The role of clinician is changing. We're seeing it become more of an informatics-based profession, leveraging the power of AI and machine learning. As part of this, we're seeing the stronger evolution of immersive systems. Again, the technologies that we're using now are based upon more than 30 years of research and development. The cost of the technology has dropped dramatically. It's possible to have an amazing immersive experience using technology that costs less than a third the cost of a smartphone. And we're seeing this technology move beyond just the early adopters, but moving out into the clinical healthcare ecosystem to those that are just using it to reduce their cost or provide better patient care. And it's really all aspects of healthcare that are being impacted, ranging from training to more objective assessments, improved interventions, new ways to facilitate clinical adherence, new ways to reach people in underserved markets, new ways to promote better healthcare on the preventive side, and new ways to collect data for research. With so many of the large tech companies investing so heavily into developing these technologies, we can anticipate it moving forward fast. Again, the technology has been building upon a foundation started back in the late 1980s, with many groups spending their careers coming up with the underpinnings of this technology. A lot of research publications supporting where we are now. We need to redo that work with more recent technology with larger group sizes, which we now can do now that the cost of the technology has come down. We're also seeing new layers to the technology. It's evolving pretty rapidly. For example, adding spatial olfactory sensation to a VR experience, or adding haptic feedback. We're seeing systems that can provide that in an affordable way now. We're also seeing better avatars that can, if we choose to, look like us, sound like us, mimic our facial expressions and body language and mannerisms, or not. But the point is, we will be seeing this evolve. We need to take steps to make sure that our personal image and avatars are protected. We're also seeing the emergence of more with cloud-based rendering. We're seeing very realistic virtual worlds that we can meet in, have experiences in. And we're starting to see, through improved inverse kinematics and better algorithms for facial expressions and body language, meeting other people in these very robust virtual worlds that don't look like robots, that look and behave naturally. Last time I took a close look, there were more than 427 emerging companies developing new XR and technologies for healthcare, spanning almost every sector of clinical care. We're seeing in some of our large healthcare networks, such as the U.S. Veterans Administration, rapid clinical adoption. The Veterans Administration has, I learned recently, more than 40 different clinical indications that they're working on. They've trained more than 2,000 frontline staff. I need to update this slide. And they're in more than 160 clinical sites using immersive technology. Why does this technology have such profound impact? Well, it's because of the fact that we create deeper cognitive engagement. We know that immersive systems activate the reward systems of the brain, facilitating better adherence and facilitating improved cognitive change. And I think we can see that there's a way of leveraging mirror neurons to create greater adherence and empathy for both for our own healthcare, but for the healthcare of others. So again, it's the full stack of healthcare that's being impacted by these technologies, ranging from training, assessments, interventions, new ways to facilitate clinical adherence, new ways to reach underserved populations, and ways to promote improved healthcare through promoting preventative medicine. We're using avatars to teach improved taking of patient histories and preparing clinicians for having difficult conversations, new ways to learn functional skills, new ways to collect assessments of both cognitive assessments and physical assessments, and ways to do a complete evaluation of all the executive functions using a VR platform. And it's not just the cognitive functions that we can measure using a VR platform. We also have ways of evoking an emotional response and measuring that very specifically using a VR platform. So all this power, especially in the field of collecting objective assessments related to cognitive and emotional status, does come with deep concerns. I was impressed by the book by Nita Farahani, focusing on the neuroscience of measurements and some of the concerns that we need to pay attention there. As we look at the spectrum of interventions that are being used, such as preoperative planning for surgery and image-guided surgery, new ways to do physical therapy, occupational therapy, new ways to address the acute needs that we have in mental health care, the full stack of application areas in psychiatry and psychology is being impacted in a very profound way using VR as for exposure therapy, for example. New ways to address addictions and new ways to promote improved health and wellness. The momentum here is substantial and we're seeing tremendous movement forward, but we do have some constraints. We do need to expand the research. The pilot studies that we've done now need to be moved to larger patient population, and we need to do more randomized controlled trials. We have to deal with the concept and perception of VR as a science fiction-y gaming platform and not as a serious clinical tool. There's a big issue of interoperability between the systems that are out there. And many of the systems being developed are based on improved clinical results, and that's fantastic and important. But we also need to make sure that as we bring this technology into the healthcare ecosystem, that we understand the time constraints and the financial constraints as we move the technologies forward. We also need to make sure that we're not over-instrumenting our world. We don't want to live in a world where everything is measured and it becomes intrusive. We need to make sure that as these systems move forward, we pay attention to good design. So in summary, VR systems or AR systems are moving forward in a very robust manner, and they're moving beyond the academic arena and the early adopter arena, starting to become part of the usual care that's provided in many of our healthcare networks. We're moving more into an informatics-based profession, giving very powerful tools to the clinicians so they can manage their patients in a more objective and precise manner. And we're coming up with new ways to move forward with the technology. So I've tried to put a lot into a very short amount of time. I hope I've covered all the major points. And I know we don't have time for questions, but Julia, thank you so much for inviting me to give this overview.
Thank you so much, Walter. This was a great overview. All right. Okay, so our next speaker will be Dr. Susan Persky. She directs the Immersive Simulation Program at the National Human Genome Research Institute, and she's published extensively in areas of health communication, genomics, and virtual reality methods. Her understanding of complex health conditions and technology position her to be an authority on the validation of immersive healthcare solutions. And this is what she'll focus on with her presentation today. Dr. Persky, are you ready to queue up your slides?
I am here. Can you see my slides?
Yes. We just need to change the spotlight.
Fantastic.
Okay.
All right. Okay, so pleased to be able to follow Walter on this one. I'm going to take a little bit more of a deep dive into thinking about how we should evaluate and arrive at what we're determining to be sort of these evidence-based approaches for use of immersive tech in medicine. And what this is doing is essentially helping us figuring out what the benefits really are when we're engaging in our risk-benefit assessments. So I'm focusing largely on immersive, but I think also really quite relevant for applications that are starting to integrate AI components, although I think, probably will be expanding our frameworks to think about that a little bit more in the future. So what I'm talking about today really started with this observation that although I think we all agree that immersive tech has so much potential to offer in medicine, we are seeing this outpouring of applications and companies in this space, as Walter was just referring to. And the reality at the end of the day was when I started sort of thinking about these issues, and still to some extent is now, that there aren't that many applications in healthcare where we feel like outcomes are sufficiently tested, capital T. And this is perhaps more important in medicine than it is elsewhere. Even perhaps more importantly, we don't have a lot of applications tested by really high quality trials. So just to say a moment about what I mean by that, these are things like use of reasonable comparators to test the application against, endpoints of trials that are measured in valid ways, best practices around data integrity and sampling of participants that are truly representing the populations that we aim to serve. So to contribute to this, to get us where we sort of need to be in this space, I sat down with my colleague, Luana Kolokwa, and we published this paper. It actually just came out. It's available open access as a resource. Today, I just want to hit a few really key points that I'm hoping will inform a little bit about what we can talk about today. And first and foremost is really our orientation towards XR as an application in health. And I think, this is going to be really relevant for the rest of the content as well. So when we're sort of casually talking about immersive health technology, we tend to talk about XR as sort of the intervention, right? We talk about it as, will XR help ADHD, for example? In this paper, we sort of talk about reasons why really XR probably almost never is the intervention. We think about XR more sort of a pill or a capsule that might control the dispersal of a drug over time. It's important for the treatment, but it isn't necessarily by itself the intervention. So an enabling technology, it's part of this larger whole. So in this vein, we laid out several aspects of immersive technology that could enable and does enable unique interventions and applications. Most of these are going to look familiar to you. But I think the point that I want to make here is that not all of these facets are necessarily important for every application. So we can't, generalize very easily on how XR interacts with health interventions across different domains. So we could think about it in the context of distraction-based acute pain management. And here we might think, okay, well, presence in an environment and the multi-sensory nature of XR could be really important here. If we think about it more around the lines of a physical rehab game, we might be much more reliant on this idea that physical activity in VR, for example, is physically, behaviorally driven, and that we can readily apply and develop closed loop systems for change over time. So really the message here is the need to focus on the content much more and the package as a whole, and think more critically about what the aspects of XR are that are going to support our intervention. So we can consider these as sort of our active components. So when we figure this out, what is it about XR that's sort of helping us out? Why are we integrating it into healthcare? We need to think about this as a key for a given tool, a given therapy, a given intervention that we are interested in, that we might want to test for efficacy. So this is a really busy table. I'm not going to go through all of these, so don't worry. But what I'm trying to do here is sort of provide a window into the resource that Luana and I are sort of putting forth. We're trying to provide clear guidelines on what kinds of claims you can make about XR tools in medicine based on the comparators you choose, based on the design of your study. So in the early days, of all of the companies starting to emerge, we tended to see what's on the bottom here. This is the no control design. It's the weakest kind of evidence, but early on is appropriate. As our ecosystem is growing, it's time for our approaches to grow up with us. So the other approaches I'm listing here, such as placebo control and specific factors component control and so on, all allow you to claim very different things about what your XR application is going to do, how it compares to other potential treatments, and why it might be effective. So if we're going to choose our design, we're actually still not done. We need to tailor our control and our comparator very carefully to our application. And then to the extent AI integration is beginning to happen, this is a crucial piece of the immersive application. And in many ways really does need to be considered very explicitly in the design of the trial. So I'm going to basically stop there, but I just wanted to put this forth as an effort to add some resources for our community, helping us to assess efficacy, helping us to assess risk-benefit trade-offs, and ultimately what are the benefits we can derive from the technology in a repeatable sort of way. So thanks for your attention. This is the program I direct at the National Institutes of Health if you want to find me for follow-up or for questions later.
Thank you so much, Susan. That was really helpful for us as we're all in one way or another doing the research in this space and trying to validate what we're doing. So our next speaker is Dr. Mohammed El-Reedy. And Dr. El-Reedy is an anesthetic consultant at the University Hospitals of Derby and Burton and the simulation lead for Queen's Hospital Simulation Center. He is passionate about immersive healthcare, leading projects that forefront the implementation of extended reality with direct patient care and educational context in collaboration with NHSE. His focus is on creating innovative solutions that enhance patient care and education. Dr. El-Reedy, are you ready? It looks like your slides are up. You're ready to go.
Yes, so
right,
thank you very much, Juliet, for the introduction, and I'm really honored to be with you all today. So I'm an anesthetist by background with a geeky interest in technology and simulation, and I'm in the context of education. And I've been using technology in education and patient care for almost about 10 years now, starting from 360 videos and virtual tools to now using immersive technology in collaboration with the NHSE and XR Hub. And starting to use AI in education as well. So my slide is just kind of an overview of actually where we are in the NHS in terms of these types of technology and in terms of immersive extended reality or artificial intelligence. We've been using them for education purposes, patients, staff. We've been using them for well-being and mental health interventions, again for patients and staff, and I've got really kind of good experience with staff well-being using virtual reality if you are interested later. So also physiotherapy, rehabilitation interventions, and pain management. In terms of AI, I have to say that I haven't used AI in the context of patient care, but I've used it in the context of education and in training and simulation training specifically. But again, there are some areas in the NHS where actually AI is being trialed and used nowadays. Actually, I want to kind of raise questions rather than give answers, because I think this is the right gathering to raise these questions from my experience with technology, specifically immersive technology. And these are the questions that I've got, and these are the areas that I think that we need to focus on, starting with safety, equality, diversity, and inclusivity. The question that I've asked myself when I'm using the technology, whether they actually, sometimes it's safe to use it. For example, patients or learners having nausea using headsets, to actually, are we sometimes, if we use this technology, are we discriminating against patients or learners who cannot use this technology for any reason or not happy to use it? Something else is the regulatory frameworks, because currently we need some regulatory frameworks that can push the technology forward, push the use of the technology forward, but at the same time maintain the higher standards to make sure that we actually are within that kind of ethical frameworks that we operate within. Also sharing experiences and collaboration between centers, between countries, between areas. For example, in NHS, they've got pots around the country where actually very good work is happening. The XR Hub, the TEL group are doing their best to kind of gather all these pots, all these people doing really great work in kind of forums and meetings to share experiences and collaborate together. But actually, are we doing enough? Are we collaborating enough? Because for example, my experience with education, with simulation using immersive technology, been shared with other people around, and also I've gathered information from people who've used it, so I'm not reinventing the wheel. Can we do that on a kind of bigger scale? Also, some of the technology that we're using, or some of the things happening in the media, have attracted kind of bad publicity, and it may have affected the public trust about AI, about technology. So when we are, again, trying to sell this to our patients within healthcare settings, how can we gain the trust? How can we make sure that they can actually trust the technology? What about when the technology fails? If you can remember, back in 2017, there was a big, massive hack on the NHS, which actually has caused in the financial loss, but also has caused a lot of loss in terms of direct patient care activities. What is the safety netting for our technology when we're using it? What happens if the technology all of a sudden stops for one reason or another? Where we're going to go? And lastly, I know that there's a big, massive talk tomorrow, I think, or the whole day, maybe. I'm not sure when, but I'm sure that you've dedicated big time for it, which is about data privacy and security. All the data is being gathered about learners, about patients, where they're kept, and how they're going to be used. So these are kind of the questions that have been kind of circulating within the network that at least I'm currently engaging with, but also in my brain. And I think these are the right kind of meetings and forums that we can actually raise these questions and start discussing them. And my feeling is that we need to gain momentum with the technology, especially the NHS, but we need also to be very careful and kind of like have some insight about what we're doing and how we're doing it. I hope that I haven't passed my 5 minutes.
That's just fine. Dr. Elredi, thank you so much for giving us this context over how these tools are actually implemented in healthcare systems and the care we need to take in how that's done and how we educate all the stakeholders involved. We are now at about 45 after the hour, so I think it's just about time for a 5-minute stretch break. And when we come back, we'll start our first discussion on the impact of AI on the patient and provider relationship, led by Richard Price. Right, so we'll take a quick 5-minute break, and we'll call you guys back at about 50 after the hour. Okay, thanks everyone.
Hi everyone, this is the 1 minute warning.
Well, welcome back, friends and peers. I hope you are well rested following that short break. And we're very pleased to resume the 4th annual Metaverse Safety Week roundtable discussion focusing on immersive healthcare and AI, and finding that balance between innovation and shared responsibility. So for those of you that don't know me, my name is Richard Price, and I will be your moderator for this first thematic discussion today. I'm the Global Health Workforce Education Specialist at the United Kingdom National Health Service, and much of my work has been around preparing the global health workforce for a digital future through digital education and learning technologies, which of course includes immersive technologies, which is our key focus today. And I have the huge honour of working with peers and colleagues around the world in the delivery of education and training with health and care organisations across the UK, but also internationally with the World Health Organization and with various governments around the world. Now, with education, we're obviously concerned about privacy with XR, but those concerns increase exponentially as we start to bring XR into the delivery of healthcare and as it starts to intersect with diagnosis and treatment. And of course, AI offers many possibilities, but imagine what can be done with those rich sources of data being generated from that XR environment. Now, Walter, in his keynote presentation earlier, mentioned 427 emerging medtech XR companies at the last count, could well be higher now. Getting privacy right is going to be key, and we need to do that right now. And that's what a lot of our focus on our discussion is going to be today. So this thematic discussion is going to include a 20-minute moderated discussion where anyone from the active contributors can raise their hand and add a 2 to 3 minute perspective or remark on the subtopic that we're discussing. And this discussion will be followed by an intelligence gathering session where all observers and contributors can take part by responding to a strategically curated question via Swarm AI, which is a very cool product, and we'll introduce that very shortly. At any given time, no personal data is going to be collected by that Swarm AI, just to be really clear, and it's beyond what's already permitted. And the aggregate output from that exercise of collective intelligence gathering will be recorded and published in that post-roundtable report. But like I say, I must stress that no personal data is going to be collected beyond that that's already permitted. So let's now review the focus of this thematic discussion for this first topic. As AI steps closer into that intimate relationship between a patient and the healthcare provider, we need to inquire about the implications on the role of the provider and the trust and bond with a patient. While AI may already play a role in clinical decision-making and AI agents may provide medical information, introduction of AI in immersive and interactive settings for patients, substituting conventional provided tasks, will impact the perceptions of each party. This roundtable is going to take us through that process and take what we know already about XR, the metaverse, and AI, and apply them to the healthcare environment to anticipate the benefits and the potential harms as well. So, before we begin, I'm very pleased to invite Linda Ciavarelli to set the stage for us with their 5-minute intervention. Now, Dr. Ciavarelli is a doctor of pediatric medicine and an ABMSP board certified specialist in primary pediatric care, pediatric care, with over 20 years of clinical experience ranging from community care in private practice to facility-based care. She has honed her expertise in preventative orthopedic and dermatologic pediatric medicine. You can tell I'm not a clinician, spluttering my words, forgive me. In addition to her clinical background, Dr. Ciavarelli is the co-founder of HouseCall VR, an innovative early-stage startup dedicated to creating virtual reality patient education. HouseCall VR aims to improve health literacy and outcomes using immersive technology. Dr. Ciavarelli is a sought-after speaker, having presented at numerous state, national, and global conferences, scientific meetings, and symposia on topics such as patient education using immersive technology in healthcare, the metaverse in healthcare, and using social immersive technology to create greater health equity. So it gives me great pleasure to introduce Dr. Ciavarelli via video today.
Hi, I'm Dr. Linda Ciavarelli, co-founder of HouseCall VR. Thank you so much for inviting me to share my thoughts and to participate in Metaverse Safety Week 2023. I'm here today to give you some thoughts on healthcare and AI, specifically as it relates to immersive technology, which is a field that we're working in. At HouseCall VR, we are developing a platform for immersive patient education. In immersive technology, one of the spaces that hasn't been well explored is patient education. Many people might be familiar with other use cases for immersive technology, including therapeutics, direct therapeutics for pain, for PTSD, for other psychological disorders, as well as for training and simulation, teaching doctors how to operate, teaching nurses how to wash hands, all of those. Our space is a little bit different, focusing specifically on the patient, developing a clinical application and using immersive technology in that space. We're very excited and also in some ways apprehensive about the use of AI in these spaces. So in healthcare, obviously, one of the places where we're seeing a lot of work being done, a lot of attention being paid is leveraging AI for diagnosis. And this is certainly something that has the potential to really reframe a lot of the conversations. From our perspective, one of the ways that is most exciting is in actually the creation tools that are being developed for the use of immersive technology that are being accelerated by the use of AI. So some of the challenges obviously include many of the things that are going to be discussed about during this conference, including, of course, safety, data, and a host of other ethical concerns. This is really a shared responsibility. We see this as a shared responsibility between clinical staff, between technology companies, between patients, between hospital systems. The whole healthcare system as a whole needs to come together and to actively work together to leverage this amazing technology in a responsible way. So in conclusion, we see an incredible amount of potential leveraging AI, specifically in our use case in content development and creation in using immersive technology for patient education. One thing that I do want to say is that from my perspective, the most important thing is to continue events like these because collaboration for ethical creation and ethical deployment is critical. Thank you so much. Again, I'm Dr. Linda Ciavarelli, co-founder of HouseCall VR. Thank you so much for having me and putting in my 2 cents at the Metaverse Safety Week.
Well, thank you for that video, Dr. Ciavarelli, and some interesting points there around safety data, the ethical concerns with this technology, and of course, for me, the most important thing, sharing responsibility for this. As Walter said right at the very start of his talk, 427 emerging medtech XR companies. So we really do need to get privacy right now. So this leads us on to approximately 20-minute discussion from our our panel our esteemed panel that I'm very pleased to invite to speak today. So on our panel today, we have Jean-Simon Fortin, who is an ER physician in Quebec and founder of Paper Plane Therapeutics. Asher Marks, a physician at Yale Center for Immersive Technologies and Pediatrics. Kimberly Halefty, Yale Center for Immersive Technologies in Pediatrics, and she's a researcher there. Susan Persky, who you've already met on the previous session, who is the NIH Immersive Simulation Lab lead, and Mohammed El Reedy, my colleague from NHS, who's an anaesthetist. Jared Kutzen, Director of the Simulation Teaching and Research Center at the Mount Sinai Hospital. Peter Oikman and Payal Gasnecker, who is the NHS Immersive Technology Lead at Torbay and South Devon NHS Foundation Trust. Also one of my colleagues that I'm very proud to work with here in the NHS. So, like I say, a very esteemed panel today. And I'd like to kick off by speaking to, well, let's start with Jean-Simon. I don't know if you want to unmute yourself and give your thoughts on what you've heard today so far and what you think the big challenges are around this intersection and building trust with patients. And I would encourage you, if you are speaking, to please share your camera as well so that we can see you.
Yeah, can you see me?
I can definitely hear you, so please go ahead.
All right. I think we heard great talks so far, and I certainly I'm fully on board with the conclusion here. I think it's important in all areas of technology to have very strict rules around data and privacy and cybersecurity, but it's especially true when we're talking about medical applications. And it's certainly one of our top priorities at Paper Plane Therapeutics, where we only collect data when we need to collect data, which is the first part. So a lot of our applications do not require us to collect any information on the patients using the technology. So in that regards, we only collect them when it's absolutely necessary. And I think there's so many frameworks and guidelines that we can follow to make sure that we do so in a way that has the patient fully protected. And I think there's not only in AR, VR, or other types of technology, but there's so many applications and ways that the patients interact with the healthcare system that can have access to their data. So I think it's really important in that fashion. And I think, you know, any company who's serious about, you know, commercialization of their technology will eventually have to go through the FDA and other regulatory bodies if it's outside the US. And having those HIPAA compliant and following the guidelines will be very important. So I think having these bodies, making sure that there's strict rules around that is key. So I think everything that was said today is in line with that.
Great, thank you, Jean-Simon. And I suppose just a slight follow-up question to that. How do you think that our partners, so ourselves as clinicians, as healthcare workers, as private companies and insurers and all of the other parts that form a healthcare ecosystem, how can they all work together to make sure that there's a safe environment?
Well, I think the summit today certainly helps so that we really understand everybody that's working in the ecosystem. How can we, you know, in some capacity share the data, because at some point getting that data and using it is key, but it always has to be, you know, in respects with the highest standards of protecting that information and making sure that the patient gives their consent to that information, which is it's nothing new. As an emergency physician, there's a lot of, you know, patient consent in everything that we do around medicine, and I think once you add technology to it, it just supercharges that capacity to acquire more data, but doesn't leave out the fact that we need to make sure that there's consent. And I think just as to serve a purpose, so people, you know, that data can be very useful. But you have to make sure that if you collect it, that it will be useful and that it's done in a way that you can collect it safely. And if you need to share it, it still has to undergo that privacy and respect whatever the patient consented to. So it's one thing to collect it. If you want to use it and share it with other people or organizations, partners, it has to be within those boundaries.
Thank you so much. Peter, you had your hand raised. Would you like to give your perspective, please? Oh, I think we might have lost Peter, unfortunately. So let's ask Sylvia from the FDA to come in. Can you give your perspective, please?
I agree with everything that was said. Basically, at FDA, I work in IT and design, but the biggest concern with HH, because we're under HHS, is privacy. It's always talked about. It's the biggest thing, privacy and keeping people's data safe. That's basically what the concern is with all the devices. Or who's the third party? Is the third party going to keep the information? How is the information going to be shared? So those are always concerns.
Absolutely. And I think these are universal concerns wherever we are in the world. So that's a great perspective. Thank you, Sylvia. Jordan, you have your hand up.
Yeah, sure. I just wanted to add real quick as we're talking about safety and privacy. I've been working in information security and privacy for about 25 years, and about half of that in healthcare. And one strategy that I found great success with that's pretty unique to healthcare is to remind folks out there that the habits you form in protecting the data isn't about protecting just your patients. It's almost always and often about protecting yourself as well, because everybody is a patient in addition to a provider.
No, you make a really good point there. I think for me, one of the big things that comes up in all of the discussions we have around AI is around trust. So the clinicians being able to trust the technology that they're working with and being able to make sure that they can trust the diagnoses and things like that. So great perspective there. Peter, you're back. You've got your hand up.
Yes, thank you. So my name is Peter Oitman, and I'm SciTech VR. And we do mental health and wellness and virtual reality. So the question, it's not a question, it's more like a broader statement. So we hear on our side more and more that people are talking about the value-based care. And this is where the struggle is for us. So how we do not collect, transmit, or store any personal information, but how could we provide a value-based care if there is no personal information? That's our dilemma right now, and we, honestly speaking, we still don't know how to solve this.
Well, that is why we're all coming together today, because I don't think these are novel problems, and I think that's quite exciting space to be in. But none of us have really had the opportunity to tackle these. So by having these discussions, we can start having that. So great point, and like that's the whole point of this discussion. We need to start the conversation going. So thank you, Peter. I'm going to come over to my side of the Atlantic now. Payal, I believe you've got your hand up.
Hi. Nice to see everybody, and it was such an interesting conversation. But one of the things that I was thinking about, and because I work in immersive healthcare and I'm looking at it from an adoption point of view, Richard, you just brought this up. How do you build trust among staff? Because if you want them to use these technologies, you want to build some transparency there, some kind of educational platform that educates them in terms of what are the benefits, what are the challenges, because this affects adoption long term. It's very easy to talk about these technologies because they're so cool, and it's easy to get distracted, especially as technologists. We tend to be in this world where we are so comfortable with these technologies. But when you bring it down to the actual staff who are going to use it, how do you change their minds? How are you going to educate them? I feel like that transparency is required. I can see this firsthand, even with just extended reality, when it's just so challenging to get people involved. So when you add the element of AI to it, it's just going to increase so many questions. So I feel like we need to address those things as well in terms of staff, not just patients, but that side as well. And another thing I was thinking about is just interoperability, because the hospital where I'm at, Torbay Hospital, we still don't have an electronic patient record system. And I was just thinking that once we start collecting this data, the reality is that there are still hospitals within the UK that don't have this ability to connect everything. And I just feel like these are all real practical problems that also need to be discussed, but these are from the operational side. So yeah, I just wanted to bring those up.
No, you make a great point there, Payal. I think there's two things I just wanted to reflect on that before we have a sort of wider discussion. What was the implication if you have a patient record, if you were to open that up, what would be the implication of sharing that data perhaps with a completely disparate system that perhaps has a different data set? Are there permissions in place? Is there trust in place between those two systems? These are questions we don't know the answer to yet. And just again, reflecting a little bit on what you were saying about the workforce point of view, it is about trust, but actually it's about people's professional registration, their license. Are they working, if they're working to their license and they make a decision based on the decision that's come out of the AI, where does that leave the clinician if it's wrong? So these are all things we need to start thinking about in terms of the impact the health workforce is having. Divya, I noticed you've got your hand up.
Hi, yeah. We'll touch on some of these privacy issues also in the second theme, but one of the important principles is that companies who are collecting platforms collecting this type of data should be looking to build in that privacy and security from the ground up, not as an afterthought layer. The second is we shouldn't be collecting data that we cannot protect, and we shouldn't be protecting data just because, even if we have no use for it. And finally, we need to, and I'm going to talk a little bit about this in the second subsection, but the idea of giving patients back some control over how that data is collected, used, what the purpose is for, and giving them the right to revoke their data as they participate in various types of, I guess, sense making of that data. And by the way, this all has to be balanced against using data in an aggregated fashion for public safety and patient good. So it is a complex tightrope.
Great point. Yes, that ability to revoke your permissions once you've already got that's going to be key, isn't it? Arjun, you've got your hand up.
Yeah, building on Divya's point here, I've worked in this space of immersive technologies and radiology for the last 6 or 7 years, and you start to ask questions, or patients even start to ask questions, and physicians start to ask questions about the secondary use of data that's being collected, right? And providing limitations or opt-outs, or at least understandable explanations to end users with limitations of what you're collecting, almost like a code of conduct for data collection, would go a long way. I think one of the challenges working with the FDA that we identified as part of the Medical Device Innovation Consortium working group there was that there is a lot of data being collected from a lot of different sensors, a lot of different reactions. I'll give you an example. If a radiologist is looking at a diagnostic image and you are now offering heat maps of where they are looking at in the XR space at a particular time, think about how many different ways that data could be used. So one of the big challenges that's been identified by many end users is, how do we opt out? How do we limit the use of data in a way that's meaningful? And one of the barriers to this is, I think a lot of organizations who are building XR applications for healthcare don't necessarily realize that they are medical devices until much later in their development.
Absolutely. And that's why I work in the education space, because we don't typically have to worry too much about some of these big challenges around medical device regulation and things like that. But absolutely, it's a huge challenge within the non-education space, within the clinical space. I know, just reflecting a little bit on what you were saying there, I know NHS England has recently awarded Palantir to give access to NHS data for improving health outcomes, but it has been met with some controversy, because I think there's a lack of trust in the technology here in the UK from the public. So there's some work to do around building that trust up if we are to do this stuff, as particularly in the XR space where you're collecting much more data than typically is collected via a normal patient record system. Susan, you had your hand up next.
Yeah, I mean, I think a lot of what I was going to say, I think Arjun just said it very, very well. But, you know, I work in genomics, and we've been using staged consents for quite a long time. So do you consent to this baseline of, you know, what we plan to use the data for? How about for secondary uses? How about for, you know, this, that, the other? And I think one of the problems that folks are starting to run into now is that with AI on board, it's very, very hard to predict what those data uses could be down the line, especially with the voluminous data that we collect in VR. So thinking through like what a broad blanket consent could look like, it's very difficult without sort of throwing in absolutely everything. And then I think the other piece that's worth mentioning is that when these things truly are integrated into healthcare, you know, how to avoid treating them as something completely other, you know, something completely unique, when there are in fact so many other healthcare technologies and applications that will be, you know, collecting more and more data and will be, you know, subject to a lot of the same questions around secondary data use. So, you know, more questions than answers at the moment, but I do think some of the models we used to lean on are sort of starting to themselves get in trouble as well.
Thank you, Susan. No, you make a really good point there. Just before we move on, just to reflect a little bit on Banajit's comment in the chat, please do keep your comments coming in and we'll try and pick some of those up in the discussion as well. Paul, I believe you were next with your hand up.
Thanks, Richard. Appreciate it. Yeah, so some fantastic comments, and you know, I agree with everything that everyone has said so far. I think there's a slightly broader piece as well, where we perhaps need to sort of apply more systems thinking to the end-to-end ecosystem, from you know the headset manufacturers, suppliers, and makers through to those creating the fantastic content, those utilizing the content, and then what actually happens within the experience itself, right? So what happens when it goes wrong? How does someone, you know, report an adverse event, right? With a normal medicine, something goes wrong, you're able to report it. There's a real kind of sort of end to end here, and we're almost talking about sort of very, very small parts of this ecosystem. So I think there's broader, deeper, richer conversation here, as well as we think about the data. We're very much focused on that patient and what they're giving and getting back potentially. So I think that's definitely one key piece. One of the other things I was thinking around, and it's something I've spoken a lot with Kavya about, and the guys at XRSI in the advisory role, is very much around some of the similarities with cloud and shared responsibility models, and how do we hold these providers of hardware and some of the systems that underpin the ecosystem of XR, how do we hold them accountable, but equally give them the tools that allows them, a bit like cloud services, to say, hey, here's what you can do on our platform and here's what we can track, etc. But if somebody develops something on our platform, where does the accountability lie? So I think there's an opportunity there as a collective group to really look at that and focus that. And that's where you can start to hopefully build in, I'll call them the EULAs, the agreements with those who then might consume those technologies, i.e. the patients, and start to have clearer accountability within the system that is going to become XR. Because if we can't start to get that right with, you know, virtual realities we're talking about here in its own right, when we start to layer AI over the top, we're going to end up in a whole world of chaos and hurt. So that's just my couple of 2 points for that piece. Thank you.
That's a great point, Paul. I think we're all guilty of scrolling through the 50 pages of Apple terms and conditions and going accept blindly without thinking too much about where that data is actually going. But I think some of this these things, the point you're making there is around transparency, I guess, of data and transparency of what you're doing with that. And I think that's going to be fundamental, really, to building trust from both a patient and from a clinician perspective. And I should mention as well, Paul is very kindly from one of our sponsors, AstraZeneca, today. Very grateful for your support with this piece of work. So we're entering our final few minutes of the discussion. Asher Marks, would you like to give your final thoughts?
Oh no, final thoughts. Thanks, Richard. Paul brings something up that I've been thinking this whole time, and that's that we need a fresh start. All of the protocols and all of the guidelines that we follow were designed for things other than what we want to use them for. And what I mean by that is that in the US we're constantly harping up on HIPAA and making sure things are HIPAA compliant. Well, HIPAA was designed in 1996 to increase privacy within a clinical setting and increase portability of insurance. And that's not at all what we're doing. And I think that we're going to continue kind of going backwards and spinning our wheels until we can get a group of leaders together to propose new guidelines as to how digital health needs to be delivered and what privacy precautions need to be put in place. We just can't be relying on old policies.
Absolutely, yes. Contemporary policies is going to be key, making sure this is up to date. If you think about the EU legislation that's just come in, how is that going to impact some of the things we want to do with AI and XR, the intersection of those two technologies? Final thoughts from Joe, you've got your hand up before we move on to what is going to be quite an exciting next stage.
Sure, yeah. So I think one of the things that seems to be coming to the surface is that some of these technologies themselves will help us to solve these challenges. And the one that sticks out saliently to me is federated learning, where in the context of AI, the model goes to the data. And so it really overcomes a lot of the challenges that were presented here over the last few minutes.
Thank you, Joe. No, another great point. Thank you. Right, that is the end of our moderated discussion. It's flown by. It really has flown by, and but I've got a very exciting person to introduce you to next, who is going to be implementing the next part of our session, which is going to be a discussion on using a technology called Swarm AI. So I'm very pleased to introduce our colleague today, David Baltax. David is the president of Unanimous AI and has produced the Swarm product, which we're going to be using very shortly. David, over to you, please, to introduce your tool.
Thank you, Richard. And thank you very much, everybody, for the opportunity to speak with you today. And I'm very happy to be able to share our Swarm AI technology with you today. Unanimous AI is the name of our company, and we develop technology that connects people together to harness and amplify their collective intelligence and enables groups to make better decisions, evaluations, and forecasts. Our technology is called Artificial Swarm Intelligence, also known as Swarm AI, and it's based on the extraordinary phenomenon known as swarm intelligence, which is nature's way of amplifying the intelligence of groups. It's why bees swarm, and birds flock, and fish school. They're smarter together when they are alone. Humans didn't evolve this capability, so we use this advanced technology to bring the benefits to groups of any size, whether they're business teams, boardrooms, executive leadership groups, and even large organizations and communities. Today, we're going to do it, and we're going to work with this body here. Our solutions have been used by the world's leading universities, as well as the largest financial institutions, market research firms, the US Air Force, and the United Nations. And today we're going to use the Swarm AI platform to combine the knowledge, wisdom, insights, and intuition of you, the speakers and attendees here today. So I'm going to post into chat and ask somebody to share it again with all of the participants, please. A link that will open in your web browser and bring you into the Swarm session. So I've posted that in chat. If somebody can pick that up, please, and
I've
share
done that for you, David, and Judy's done it as well.
Great. Thank you very much. It will open up a web browser. I recommend using a computer or tablet. Mobile devices will make very small real estate. I want to just reiterate what Richard said earlier. We are not collecting any personally identifiable information beyond what has already been agreed to. And so we are hoping that you'll be able to participate and join in Swarm with us all. For those of you, for some reason, are not able to join in, I see it is being shared in the Zoom window as well. So thank you for that. I see that we actually already have a good number of people. Keep on coming in. Please join as you can. We are going to combine all of our input with the Swarm AI technology to gather insights and unlock the collective intelligence of the group. When you put your mouse next to the spinning glass puck, it turns into a magnet. Your magnet is green and everyone else's magnet is gold. Use your magnet to pull on the puck. In a moment, I'll present a question and actually a series of questions, and a set of answers will appear on your screen. Our goal is to work together to converge on the best possible answer that we can in 60 seconds. So you should pull for the answer or answers you believe in, but remain open for compromise if you think is appropriate so that an answer can be arrived at in time. So a few things to keep in mind as we go through this. The closer your magnet is to the puck, the stronger its pull. You don't have to click or swipe. Simply keep repositioning your magnet so it's pulling in the appropriate direction. Keep in mind you need to pull continuously with your magnet during each answer. If you're not pulling on the puck with your magnet, you have no impact on or influence over the outcome. Again, our goal is to converge on the best possible answer for each question by combining our knowledge, wisdom, insights, and intuition. So let's try a warm-up question to make sure everybody knows how to manage the puck. We'll place that into Swarm right
Just
now.
before we do that, we're just going to check that and reiterate that everybody can access this. So regardless of whether you're just a participant or whether you are an observer, you are all very welcome to take part in this exercise. And we'll paste the link in the chat again.
All right, very good. So you can see the warm-up question now on your screen. What was the most important invention of the 20th century? Set your magnet during the 3, 2, 1 countdown at now, and let's see if we can work together to bring the puck to the answer that we can best agree upon. Excellent, well done. You'll note also on that, that little billboard there, we can see a conviction score of 76%. Pretty good. That gives us an indication of how well aligned the group was overall as it came to the answers that it did. So we're going to start with doing an ordering exercise. We're going to consider some options. We're going to consider some options specifically around which of these and work on ordering these options to identify which of these is the greatest concern regarding AI impact on the patient relationship. And so actually, Julia, I see since we're skipping the first question,
yeah, we've just been talking about this due to time. We're going to skip the first question and move to the second question, which is actually 4 questions. So we'll give you all the opportunity as participants to be able to work through that.
Great. So I'm going to post this question into Swarm. And we are specifically asking, you can see a set of concerns right now. And this is with regard to the relationship between patients and AI. Which of these is the least concern? Okay, very good. So we've identified bond with AI as the lowest concern in terms of that relationship. Now I'm going to remove that option. We're going to repeat that question now with the remaining 5 options. And we'll go through this entire process here as we put all of these in order. So which of these is the least concern? Very good. This one had an 81% conviction, so getting stronger here. I suspect this will get a little more difficult as we go. We'll remove that option. There are now 4 choices left. And again, we want to consider which of these is of least concern. Very interesting. Thank you. Okay, we'll have now 3 options left. We'll go through the same process as we did before, and we want to consider which of these 3 is of our lowest concern. Okay, now that we have it down to 2, I'm going to change the question a little bit. So we have it down to 2 options. And what I want to ask now is which of these remaining 2, breach of privacy and inaccurate information, is our greatest concern, which is of most concern. And we want to, you'll have the opportunity to consider breach of privacy, which will be on the left side, and inaccurate information, which will be on the right, a magnitude. How much more than the other one is this as a concern? So you'll see here what is of greatest concern. Breach of privacy is on the left by a little and by a lot. Inaccurate information by a little and by a lot. Excellent, thank you. So now what we have just done is we have ordered all 5 of those, 6 of those options, and collected, in addition to the group's collective intelligence as well, your collective confidence and conviction in those choices. I'll turn it back to Richard.
Thank you, David. Wow, that was an amazing exercise and a fun tool as well. Really excited to have the opportunity to use that today. So I'm going to call on all of you. Were there any surprises from that exercise? Were there any reflections, anything that you weren't expecting to see as a result of that? I must say it's a tough ask when you're trying to think about the impact of privacy and the impact of accuracy as the 2 options, because they're both equally important in my mind. But I guess you would prefer to have an accurate diagnosis rather than and take the consequences of that. So any thoughts on that? Kavya, you've got your hand up.
Thanks, Richard. Can't come on the camera right now, but I still want to chime in because especially for immersive healthcare, how we understand privacy generally is like, oh, the information is lost, or is it private or not? Whereas at XRSI, we've kind of established when it comes to immersive care or immersive technologies, we have to care about at least 4 major things. So within XRSI privacy and safety framework, it's context of the information shared, control, whether the person has control over the information, whether it's being shared or not, but also has the choice to be able to share. And then finally, because of brain-computer interface related data, biometrically inferred data, we have to also consider allowing the respect and autonomy. So these are the 4 components that collectively make privacy. When we look at that, and then we look at inaccurate information being the other thing, it feels to me they're both so important. It almost like impossible to say one is more than the other, because all of that matters.
Absolutely, yeah, tough decision there. So thank you for those reflections, Kavya. Jordan, you have your hand up.
Yeah, I just wanted to make a quick observation, which is that given the diverse perspectives and the folks in the room, so to speak here, I'm actually pretty hopeful about the fact that everybody put, accuracy of the information first. So I assume that means outcomes matter absolutely most to everybody, as I think it should be. But I also like the fact that the very next thing on the list is privacy, honoring the patient themselves and kind of the information that we're gathering about them, what we're doing with it. The fact that those are the 2 highest priorities of all this, I think is a great reflection on maybe this industry as a whole and our approach to even these brand new emerging technologies that people are still learning about and don't fully understand.
Absolutely, yeah. Interesting that those two areas were highlighted. I wonder how many clinicians we actually have on the call today, because I wonder how big a deal trust would be if we were just talking to a group of clinicians, for example, which was one of the options that got discarded quite early on. Julia.
So in the chat, I put the rank order that was provided from the polling, so from the lowest to the highest, with going from bond to accuracy of information. So I just want to point your attention to that. And also to add in that when we're thinking about AI in that patient-provider relationship, it's also the patient interacting with AI, whether it be through a conversational bot, through an avatar, not just the AI in clinical decision making that happens in the background. So as we're developing these immersive technologies, we're changing how the patient is interfacing with their care. So I just wanted to add those 2 cents as well, and the reason why we have bond and bedside manner in those options to consider.
Absolutely, thank you, Julia. So we're reaching the end of our time on this discussion on the provider-patient relationship and trust and all of the other things that go with that. I think it's fitting, perhaps, Mo, you should have the final thoughts on this, because you are an anaesthetist working in healthcare. So any final thoughts before we close this part of the session?
Yeah, speaking as a clinician, I think there's a personal responsibility on especially diagnosis. A wrong diagnosis or a wrong information can impact you personally, and this you can take that as a personal kind of a thing, rather than a breach of information, which can be kind of in the context of constitutional or not constitutional institutional problem rather than a personal problem. So I think clinicians would be rather keen to have breach of information in comparison to kind of a problem with the diagnosis or wrong diagnosis.
No, that's really helpful to have that perspective, because that does reflect actually what the swarm was indicating. So with that in mind, I'm going to close the conversation there, and we're going to have a short break. I think it's fair to say we've covered a huge amount in a very short time today, and we could probably have continued this conversation for several hours, if not days. And I think hopefully this is the start of that conversation that needs to be happening around this space, and hopefully we can take this much further. So thank you all to our contributors, to our speakers, and to David from Swarm for facilitating the Swarm session today. We're going to have a coffee break, and we'll be back in approximately 10 minutes time. If someone could please post the exact time in the chat.
We'll be coming back around 1:03 for a lunch break.
Perfect. Thank you so much. Enjoy your lunch, everyone.
Hi, everyone. I hope you had a good break, and we will resume in about 1 minute.
Welcome back, everyone. So we are moving into our second half on a different, well, all our topics are related, but a different topic led by Dr. Divya Chander. So as we're coming back online, I hope we're in attendance. And if you're here, if you can turn on your video, then I know for sure you're really with us at this time. Dr. Chandra, would you like to begin with giving an introduction to our next topic?
Yes, thank you so much, Julia. All right, so we're now resuming our 4th annual Metaverse Safety Week roundtable discussion focused on immersive healthcare and AI, finding the balance between innovation and shared responsibility. My name is Divya Chander. I'll be your moderator for the second thematic discussion. I happen to also be a medical advisor to XRSI. Professionally, I am a practicing anesthesiologist and an applied neuroscientist. I write algorithms to automate tracking states of consciousness in the operating room. I'm also the founder and CEO of a digital neuroscience platform that works to detect and prevent brain failure. And I work with several think tanks like the Stimson Center to enable cyber health security and good data policy that benefits the public. So our second thematic discussion is going to include a 20-minute moderated discussion where anyone from our active contributor group can raise their hands and provide 2 to 3 minute remarks on the subtopic. Then this open discussion is going to be followed by that same Swarm AI intelligence gathering session. To remind you, we are not going to be collecting your personal data. You will be anonymized, but the aggregate output, and it's kind of exciting for everybody to participate, will be recorded and published in our post-roundtable report. So I'm now going to review the focus of this thematic discussion. Our topic is data privacy and patient agency in AI-enhanced immersive healthcare. So the range of sensitive healthcare information in immersive contexts has been greatly expanded. These data become fuel for AI models that may benefit or exploit patients. A crucial balance between maintaining data privacy and empowering patient agency over this data must be set. The discussion will explore strategies for robust data protection and compliance with healthcare regulations, focusing on the unique challenges of securing sensitive health information. Additionally, the discussion will emphasize enhancing patient autonomy, ensuring informed consent, and maintaining transparency in AI interactions to uphold patient rights and ethical standards in healthcare innovation. Now, this is actually a huge topic, and we are not going to be able to get to everything. So the first thing I want to say is this should be an ongoing discussion. If you're all here, you're all an interested community member, and we want to keep hearing from you. So here are some of these other discussion topics that I hope come up with our panelists and our audience. But if we don't get to everything, like I said, we would continue to encourage your participation with us. So the first, what are various data types, biometric or biometrically inferred, that are now being collected? How have these changed from traditional recordings in a clinic or a hospital-based setting to wearables and citables and implantables, to passive and monitors that you might find daily in your built environment? How are these integrated with extended reality hardware and in the creation of digital twins, as Walter Greenleaf was alluding to? And then next, how do these new monitoring and twinning issues change the risk landscape when entering a digital health, mixed reality, or consumer application environment? Another very interesting and important point, and this gets to consumer and patient education. How aware are people that their digital healthcare and XR data is being collected in the consumer space and that it's not protected or treated in the same way that it is in a healthcare domain? It's the same data, but it's really not being labeled or secured in the same way. Think about things like your heart rate data that may be collected by a healthcare provider versus a Fitbit or a smartwatch. Another important piece of this, and I really hope that we get to this because we do have some panelists with expertise in this area who are working on this. What is user or edge-based control, operations, and processing? Now, just for those of you who might not be familiar with this terminology, an edge-based device refers to a piece of technology or a sensor like your Apple Watch or a smartphone camera or even an Alexa that performs computing tasks or processes data locally, closer to the source of information, rather than relying solely on centralized server or cloud infrastructure. So these devices can bring computational power closer to where the data is being generated or where it's needed. And that enables the Internet of Medical Things devices to perform tasks without always relying on constant internet connections or a centralized server. It's also good for training models on local data, but that's stored at the edge. And so one of the things that we need to start thinking about is how much local or edge storage is possible on these devices, how much processing at the edge is possible, how will the improvement in artificial intelligence chips that are smarter, faster, and cheaper enable enhanced privacy by enabling distributed or federated learning at the edge? And can we perform operations at the edge, but still utilize this data to train and improve models that serve both our individual patients' health and public health? Another really important question is, who owns the data that is produced? Is it the data producer, that is us or our devices that are producing things on an individual level at the edge? Or is it the platform or software company? Is it the hardware? Is it the hospital, clinic, or provider environment? It's really difficult to know right now. And another piece of it is then who benefits from the data that is produced. The data producer should be, but in many cases they don't. It's researchers, clinical providers, and companies, the software hardware enablers like Google, Amazon, Apple, Meta, Medtronic, Masimo, and definitely pharma companies are benefiting. And finally, I want to tell you how many stakeholders there are and what their interactions should be in this whole data and privacy issue. So there are the healthcare providers, there are the developers and companies, and I am now in that category, even though I am a healthcare provider, and there are many startups here who are working in the extended reality patient space. So how do these people protect user data? How do they protect the users themselves? How do they enable users to use their data, but also interact with that data appropriately to train their models? Because without training models, we can't improve healthcare. How do we get patients involved in the process of informed consent? What does that even mean? How is informed consent different than an end user license agreement, which typically protects the company and not the person producing the data? What if your patient can't give informed consent? They're unconscious, they're on sedatives, they have dementia, or they simply don't understand the implication of the technology. And finally, from the data producer's perspective, what can they do to actually demand some of these user protections or potentially interact with their data in a healthcare vault or enjoy differential privacy? So I want to introduce all of these different topics because they're all really intimately important in this era of AI, immersive healthcare, digital privacy, and digital safety. And with that, I'm going to now introduce our next panelist, Natalia Kosmina. She's going to provide a 5-minute perspective in this space.
Divya, sorry to interrupt. We just need to change the order of things. Natalia is dealing with actual physical world emergency, so she's going to come back in like 30 minutes. So we'll go to
no
discussion.
problem.
Yeah.
Okay, so what we can do now then is, given that I set up this sort of broad, like, I guess, menu of different topics that we can discuss, I'd like to introduce our panelists. We have Walter Greenleaf, who's back with us from Stanford University. We have Charles Binkley, who is the Director of Bioethics at Hackensack Hospital. We have Nina Somareddy. She is the CEO of Neuro Rehab VR. We have Brendan Hale. He was formerly of Penumbra, and he is a researcher of immersive digital technologies focused on measuring relevant clinical outcomes. We have Dorothy Caminiti, SCU Marquillis Center, and Andreas Forslund, co-founder and CEO at Cognition. So I'd like to invite you to speak, any of these panelists, on these topics for the next 2 to 3 minutes each. So I see Andreas has his hand up. Andreas, I'll turn the mic over to you.
Good afternoon, everybody. My name is Andreas Forsland, founder and CEO at Cognition. We're a BCI company that works in augmented reality and builds AI technology in service of patient agencies. So this topic is near and dear to our hearts as a company. I wanted to first maybe frame a little bit about some of the things that we're thinking about. First of which is this transition from a triple aims of healthcare to a quadruple aims of healthcare, and sort of adding yet another stakeholder in the mix as far as not just the patient outcomes and patient experience and cost of care, but also thinking through the provider experience. Provider experience being their quality of fulfillment of doing their job as well as their own productivity. So AI plays a role also in that regard, not just in the patient experience, but also in the delivery side. One of the things that I would like to also frame is this notion of time. Time specifically regarding time to outcome, or in more technical terms, latency. So if we think about the latency in system design and in how AI performs, latency can make or break certain kinds of healthcare systems. So on the most extreme use case of very low latency, very high frequency processing and compute, you're talking about like a neural prosthetic or a neural bionic that needs to operate in millisecond time, and it needs to be very adaptive as far as adaptive AI. On the other end of the spectrum, where time isn't as crucial, you might have time lapsed or time delayed information, such as processing visual imagery or making diagnostics or other kinds of things. And so you have this time domain that directly impacts strategy for how you would implement machine learning and AI. And so if you think about the need for high speed, i.e. low latency, high frequency, number of samples per second throughout the day or throughout a particular session, it pushes more of a technical strategy closer to on-device and on-edge compute, whereas you might have a tolerance for your systems to be more latency, or you don't need as many samples, such as in a cloud instance or edge compute. So thinking through the manifestations or how you would manifest a solution, your AI strategy may be very, very different. So like our perspective, we come in from a nearly real-time perspective. And so our strategy and what's of interest to us is how do we deal with AI to augment a human's ability in real time to increase their physical agency, much like you would a prosthetic. So I wanted to kind of set that out as a framing because I think when we sort of, it's very easy to sort of mix stakeholders and really somehow confuse strategy versus tactics on what we might need to do to understand policy and how it applies to each of these different kinds of implementations or use cases. And I think there's also one last point is there's been a lot of work by many regulating bodies, the FDA, IEC, ISO, IEEE, you name it. And there's existing regulations and standards that you need to design for regarding cybersecurity, data privacy. I just think that more, if you're in the medical device space, you're very cogent on these standards because you have to meet these standards. I think the sort of the adherence to these standards gets blurry to the point where people that are in pure consumer use cases don't even know that these standards are available. So thinking about the education and awareness of some of these standards, that we don't necessarily have to rewrite the rule book per se, but we have to potentially at least have a heightened level of education and awareness of what's already been done so that we can conform to certain standards for safety and efficacy.
Actually, that gets to a really good point that was brought up maybe by one of the panelists who was commenting in the chat. Is this too much of a burden for small companies or startups? And then, Andres, where would you see this sort of shared partnership between consumer or patient end user and the company itself in terms of the responsibility?
Well, I think the first thing that you need to do is identify who is your customer and know who they are and be able to. One of the things that we did early on is we created an advisory council as a company. So an advisory council of users, and we have a 5-to-1 advisory council member to employee ratio. So we're taking in a lot of feedback from users with certain kinds of medical conditions that would benefit from them, and co-designing with them as opposed to for them. You'll accelerate innovation and increase your odds of success by doing that.
Mm-hmm. Co-designing actually with the user in mind came up a lot during yesterday's Swarm Intelligence during the Human Rights Day. So that's a really amazing point. I wanted to turn the mic over actually to Walter Greenleaf for his comments.
Well, thank you. It's so exciting. One of the things that struck me while listening to the wonderful presentations and discussions so far today is that the use of the term design, the term user input. I think one of the trade-offs that we need to make is putting the right amount of effort into reaching underserved populations as we go about designing our recommendations to move forward in this field. We know that looking downstream to look at the potential issues that are going to be relevant as we're doing now needs to be brought forward to everyone and have solicit input from potential patients, current patients, future patients at large, and ask them about the trade-offs. I love seeing the demo today of the Swarm way of balancing issues. I think the more we can pose what the trade-offs will be, because there will be trade-offs. I think that balancing access to data, speed of assessment, we're already on the other side of the issue where playing an online game in a virtual reality environment where your voice might be used to score your level of anxiety or depression, and your behavior in the online game may give you some analytics to identify your ability to pay attention and on task, or how to work well with others. This is public information that can be harvested and identified and mapped to a person. So we're already on the other side of using psychometric data to compromise individual privacy outside the medical ecosystem. I think within the medical ecosystem, we have a structure to protect data. It does have some nuances that need to be shorn up and reinforced. But since we're already putting the use of wearable sensor technology, machine learning, and analytics in such a way that everyone is at risk for having their personal data transformed into some data that indicates their mental health, their emotional state, we need to quickly get out there and ask people, how do we trade off the power of this for the potential value in our healthcare ecosystem? And I'm not aware yet of anyone who has an initiative to directly go out and pose those questions to the public at large. I'm hoping there are groups that are doing that.
I think that XRSI to some extent is involved in doing some of this work through the privacy and safety framework, but not necessarily a caveat from the public outreach standpoint. Are you able to speak to that?
Yeah, sure, Divya. So we totally defer to the Medical XR Advisory Council. So mostly under the leadership of Julia, the way it has been working so far, just like Metaverse Safety Week, we tend to target the world leaders, and we tend to target the organizations that could lead the charge for public education. We don't necessarily directly influence the public, the citizens, etc. So all the knowledge, research, etc. is always directed to the leaders, because it's almost impossible for a tiny nonprofit to influence, world citizens. And that's why, I just recently even heard from the White House, we have like sort of a direct line with FDA and, with various entities, and of course, NHS being the organizer. So this is our indirect way of influencing things, which is feasible, but it certainly leaves the room for somebody to really take the helm on that public education side.
Well, I'm not so much thinking education or influence. I'm thinking collecting information about people's preferences when it comes to the balance between protection versus trade-offs for better healthcare. If we have a looser system, what do people in different subpopulations? What are their preferences? So more of a research project than an educational project.
And it is a good point, because another thing that came up a lot during Human Rights Day was how is it that users are able to interact with their data, revoke consent, talk about how it should be used, if they're completely uneducated on what's happening with their data, what their digital rights are, what privacy means, what's an informed consent for somebody. All of these things probably would be enhanced or aided by the type of reach out you're talking about, Walter. I see Brendan Hale's hand out. I'd like to call on you to speak.
Yeah, one is I'd like to reiterate what Walter's saying, and I think there's some really interesting future-looking efforts here, but also some ongoing efforts. I like to refer to it as data agency. How much agency do you have over your own data, and what are you willing to do with that data, or what are you willing to allow others to use with that data? And so I can use a couple of examples, and I'll use Patients Like Me as an example. And Patients Like Me is an organization that started to connect people into cohorts of other people who have similar conditions to themselves. But in the background, they were also, willing to gather data and gather information from those individuals based on how much they were willing to share and how much they were willing to allow their data to be used to help inform future research and help inform future efforts to aid others with that condition. And if my recall is correct, Patients Like Me had great success with those individuals and getting them to share data and share information so that it was benefiting the entire community. And so I think there's not only data agency, but then there's value of their data to other individuals, or how it can be used to benefit other organizations. And so I think that data agency is really an interesting component of this idea of what can be used. To Walter's other point, what I think is also really interesting is that we're able to collect data, if you will, on the preventative side that could help inform the clinical care. Now, the question really is how do we create the opportunity to pass that through to our clinicians and share that data with our clinicians so that I maintain my data agency if I'm the person sharing it, as well as then providing the privacy and security that's necessary to ensure that data is only used for the purposes that I agree to. And so, I guess at the end of the day, really what I'm highlighting is there are some exemplars out there of people doing similar things, but I think the key is starting with data agency and allowing each individual to own their data and to allow their data to be shared in the way that they desire.
This actually brings up a really crucial point, which I mentioned only in passing, but currently, especially with devices that, Andreas was talking about the blurred sort of space between consumer and XR for health. Many of these companies, when they want to interact with a consumer or an end user, even if it's for health purposes, they still provide them with an end user license agreement. First of all, those are always in legal language. How many patients even really understand? I don't understand most of what's in a EULA. It takes too long to read. If English is not your first language, you'll have a lot of difficulty with it. These may not be targeted to someone's grade level. And in the end, they're written, like for instance, there are arbitration clauses in there. They're not written to protect the end user. If you don't agree, you don't get access to the product. they're written to protect the company. And if we were to move to something a little bit more like an informed consent type of situation where we made sure to present data use, data storage, data privacy, the right to revoke access to data in a way that the end user could understand and receive that information, I think we'd make a lot of progress towards end user agency and data agency, I guess, over the use of that data. There are definitely two. Oh, I see Julia's hand up. I also want to make sure that I have a chance to include Dorothy in bioethics and Ryan Cameron, one of our medical XR advisors, who's actually been working in the space of digital identity at the edge, interoperability, standards, and naming. But Julia, I'll have you go.
I'll be brief, but I did want to kind of bring in an example where we're looking at the trade-offs and where these are really a matter of choice, not the technology capabilities. And if you take a look at not AI interfaces for mental health, which there are quite a lot out there, you can look at the same product in one healthcare system that puts patient privacy at a premium over intervention, where the interface with the AI is completely anonymous. And so if there are flags for at-risk behaviors, at-risk thoughts for youth, that person who is at risk of, say there's indicators of suicide risk, they get a flag that they should go get care. But no care provider is informed because the platform's anonymous. That same platform implemented stateside and in California with minors does flag to a healthcare provider or to a mental health care provider, where you do make the choice that the delivery of care or the prevention of harm comes above the privacy of the minor using that AI tool for mental health. So it's really a matter of a lot of these things, a matter of choice. It is a matter of technology, especially when it comes to the encryption, data transfer, and storage. But much of this is how we choose to use it and balancing these trade-offs. All right, that was all.
No, it's a really important comment. This is a really difficult subject to deal with, actually. I see that Paul Jones has his hand raised.
Hey, I was just going to say there's actually some really interesting work going on by Tim Berners-Lee. And I think it's MIT looking at Solid, which is the whole premise of flipping that data model on its head and putting it back in the hands of the individual. Now, that's probably a ways off before it's fully implemented and we really understand what the art of the possible is and what that may or may not deliver. But that is one way where hopefully, as these technologies evolve, that ownership will move back towards the patient, the individual, for example, which I think is something which will make a huge difference. But I think Divya, you made the point there. It doesn't necessarily kind of resolve that issue around literacy. And I think as much as this technology advances, there's still a huge challenge in terms of literacy. And that's something that all of us collectively need to up our game on, helping individuals up their game and collective society understand, back to the swarm questions around what's happening with their data. What does this even mean? When we talk about doctors and trust, there is very much, you go to your doctor, there's someone you've known, you have a relationship for a long time. There is an element of trust. You're suddenly, to Julia's point earlier, again, speaking to a doctor who's an avatar all of a sudden, and you don't have that trust, and it's going to be absolutely critical. And that then comes back down to, is the processing happening at the edge, or is that via the cloud? And somebody else mentioned speed, and it's going to be a real juxtaposition, of all of these things coming together. That's really going to kind of sort of deliver
Two things come to mind.
Utopia that could be
Oh, sorry, go ahead.
No, I was going to say that's just where all of those things are going to converge, potentially, hopefully in this utopia that means that patients get the right outcomes.
Just to reflect on what you said, Paul, one thing that came to mind when you were talking about trust is that it's very interesting, but often patients and citizens tend to trust bots or avatars more than they do their physicians, because physicians maybe aren't very good at embodying bedside manner or empathy or compassion. And so they feel less judged by something that they know is not human. So I think that this trust issue may go both ways when we're interacting with digital versions of the healthcare provider. To the other point that you made, and I'm so glad you brought it up about Tim Berners-Lee's Solid, there are a number of alternate network architectures that can be deployed in the internet that are actually especially good for securing data at the edge, making it better named. Named data networking is one that comes to mind as well, that are conducive to differential privacy, to special kinds of protection of digital identity at the edge, and creating those health data vaults for transactions. So thank you very much for bringing up both of those points. I see Kavya's hand up.
Just going to be real quick, but I think as a part of our XRSI privacy safety framework research, we looked at Solid, we looked at NDN as well. The issue with this, as well as homomorphic encryption and many other really remarkable algorithmic concepts that could revolutionize the way we approach data, is just adoption, the feasibility, and there is so much more work needed before we can say, okay, that's the solution. Solid's awesome, but it's like not ready for prime time.
It's not quite yet. Actually, on that subject, though, one of our XRSI advisors, Ryan Cameron, do you want to speak to that? Because I know you've been working on homomorphic encryption and protecting data at the edge and interoperability with NIST.
Yeah, so I did look at using blockchain and homomorphic encryption and Solid and NDN, and I've been consciously building these kind of systems, and through experimenting with all of those, I ended up at a kind of something called envelope encryption. So what this does is it enables I'm going to turn my video off. This looks ridiculous. What this does is it allows the end user to control a security key, and then they can use cloud services to control the security key through key management service. And then their data can also be controlled by them, and access to the key can be granted at the application level. So I've kind of been through all of this, and what I've come to sort of conclude after working on all these different kind of systems and pretty extensively with Google Cloud Services, that which is similar to Azure and AWS, as I understand, is that this really needs to be implemented at the developer level, like right in the interface, and all the opportunities for consent and informing the user and engaging them, or their guardian at the beginning, or giving caregivers or clinicians the opportunity to act in the best interest of the patient, and then give them control at every opportunity. That all has to be done at the design level. So when you're designing the application, so I think the place to engage that would be the most effective, while I think Qualcomm and what they're doing is really cool with doing compute at the edge, but I think it really is at the sort of Unity developer level, because we're the ones who are making all those critical decisions about when to engage patients and what to say to them, because we just kind of get left to that by default. So I think if regulators start to look at providing tools to developers and regulations that they can follow, and templates and stuff that work in their world, which is the rich media world and the XR VR plugins and development tools, I think that's the most effective place to be. And the other thing I wanted to mention is the big challenge with Solid and blockchain in particular is just the sheer amount of data that we're recording. So we need to be able to keep huge amounts of data that's streaming encrypted all the time, but also decide, what parts of the data don't need to be encrypted because it's not important in terms of privacy, but by not encrypting it, that those parts of data become useful to researchers and clinicians for other purposes. So that's a whole other thing. But if anyone wants to talk to me about what we've been doing, I think Kavi and I have been working on a paper that we'll be releasing soon about it.
That's worth taking him up on. And it's a good definition of a stakeholder role. I see we're going to need to move to Swarm in just a minute. Brendan, if I give you the floor for a minute, do you think you can close us out?
I can close you out much quicker than a minute. Divya, I was going to pick up on one of the things you said about trust. And what we're increasingly seeing is that people who are digital natives have more trust in the virtual bots and the virtual humans that they're able to interact with. And so what is interesting is that the younger and younger generations who are true digital natives, many of us are kind of transitional digital natives, if you will, but the true digital natives are very trusting of these interactions with whether it's healthcare providers or it's counselors or it's coaches or whatever. They're very trusting of that, and so it does change the interaction and how we need to think about these in the work that we develop.
So that was a really good way of closing this out. I think this was a pretty rich discussion on the interaction between all the different stakeholders and some of the concerns about data and privacy. I now want to pass this off to David Baltax again, so we can do another one of these amazing sort of swarm collective intelligence exercises with you. David?
I'm double checking that he is ready. I did message him. There he is. Perfect.
But I'm on mute, so it took me a moment. Apologies. We are going to use the same link that we did before. I have posted that into chat and asked others to repost it as appropriate. Really look forward to running through this next set of questions here with you all. So please rejoin Swarm. I can see a few people are coming back. Those of you who never left, that's great. Please put as before, please put your mouse pointer next to the glass puck. You'll see your mouse pointer will activate your magnet. Your magnet is green and everybody else's magnet is gold. And so you will, as you might remember, use your magnet to pull. You do not need to click. You do not need to swipe. Just continuously reposition your magnet so that it stays proximal to the puck, and start by pulling for your first choice, and consider how we can work together to bring the puck to the best answer that we can collectively. So it looks like we have a good number of people. I'm going to get started here. The first question we want to consider is, how important is it to know how AI decisions are made? How important is it to know how AI decisions are made? Interesting, thank you. Divya, shall we just keep moving forward through all the questions, or do you want to pause and reflect?
I was going to say that we could probably move to the next question, but I might want to pause and reflect after the next one.
That's absolutely fine. Just let me know.
Sure. What else, by the way, was pulling it? Was it somewhat important, or what were the other choices?
In fact, the swarm seemed to really focus just on two choices, and it was between very important and somewhat important. Really, the other options got fairly low levels of support comparatively. All right. In this question, we have a number of different options. We want to consider, how should consent for data use in AI applications be obtained? So I'll give you a few seconds to be able to review that. What's the best option?
So that was interesting that we came to that one pretty quickly, didn't we?
Yes.
And I wanted to open the floor just for a couple of minutes. Does anybody want to reflect or comment on why they chose what they chose? It looks like Sylvia does.
I actually wanted to comment on the first one. I'm part of a marginalized community all around. So I'm very concerned with how AI makes their decision on everything, especially healthcare. Because basically just from working at the FDA, it's found out that African American, which I am a group of, have a very bad, the FDA has a very bad reputation with African American because they don't trust HHS or any of their on any of the agencies under them dealing with healthcare, which is very sad and scary based on history.
Thank you really very much for that, actually. And you can imagine that there is a difference in the way different end users perceive the need for this transparency because of exactly what you mentioned. Does anybody else want to reflect on the first two questions, either of them? It looks like Andreas does.
Well, yeah, as an operator, as an entrepreneur, I would say that in an academic setting, I don't disagree with that last exercise. As an operator, I would say that would add an order of magnitude to the cost of care. If you tried to force a patient to opt in to every AI feature in order for them to get care, it just wouldn't happen.
That's a really good point. Just on a practical level, does this change people's thinking about the importance of an umbrella opt-in versus a piecemeal opt-in? By the way, Andreas, are you for opt-in versus opt-out?
I'm on it kind of depends, right? So if the person has cognitive ability and the ability to express their motivations or their intentions, then I lean towards an opt-in. If they're in a life or death situation, then it's an opt-out.
Jordan?
Yeah, to kind of continue on Andres' comment there, I think kind of two things are important here. One, it might be worthwhile to consider the difference between what we mean by item as opposed to, like, are we talking about elements of data? Are we talking about use cases? Are we talking about research and projects and or companies, that kind of stuff? I mean, it's a little broad, so I think that can matter and help kind of address some of those issues. And I'd also say that this gets back to the issue of trust. Part of the reason that most of us are default sense is to have that fully informed opt-in care is because so many companies and organizations have done what is generally considered to be the wrong things with the data that has been shared with them, especially where we didn't have a choice, that a lot of that trust has to be regained before we're willing to make things easier on the companies that are gathering and using the data.
Also an important point. All right, I think we should probably go on to the next swarm question.
Okay, so if you'll please return your attention back to your browser, to the Swarm window, you can just confirm that your magnet is working. If for any reason your magnet is not responding at this point, just refresh your browser and you'll be right back in. The next question we want to pose is, who should be responsible for managing patient data generated by AI? Okay, 73% conviction. Pretty good. Pretty good. Moving forward. The next question has
Actually,
to...
David, I was going to say one thing in response to that. I was in the minority. I chose software. And the only reason for this is because that's pretty much the point of, it's the maximal point of data interaction, because that's where the data is being labeled, held, aggregated, possibly encrypted. And there is a lot of data, as we've discussed, that is not being collected in the healthcare context. And because of that context dependence, I think that the software provider might have a much larger role to play.
That's a really good point as well, especially with stuff like transit impact assessments and EU laws and regulations. Well, whilst we might want the utopia of the healthcare system owning it, actually, there's going to be a lot of trade-offs as to who doesn't actually truly own that data.
Okay, David, on to the next question.
Sure. Just confirming. Yep. Okay. So on your screen right now, which is the greatest risk to patient data in AI applications? Greatest risk. Thank you.
Does anybody want to either reflect on why they voted similar to what the group consensus was, or maybe chose something else? Sylvia.
Again, since I am in the US and work for the FDA, I'm going to go with privacy. I disagree. I think privacy is the number one concern in general with everything. But that's just mean like your privacy. Like if somebody can read everything about you through AI, that's scarier to me, but that's just me. And just from what I know about the FDA, it's like you. So.
Thank you for that, Sylvia. Kavya?
Yeah, I think misrepresentation, inaccuracy, I mean, it's obviously something, but it really becomes so critical when you have vulnerable population. And I specifically want to talk about, elderly population, specifically for immersive care. They are currently, there have been so many research that are like VR is great for them, etc. But consent obtaining from a person, earlier Brandon was saying, if they have the cognition and ability to share consent, only then. So I really wonder from this group, like, what happens when they don't even have that? So that misrepresentation could happen. That could be on behalf of the patient, that could be exploiting the patient. Like, I don't know where the answers are, but that's the question that's been on my mind. And I know we have some observers here who are also interested in that very aspect.
Well, just to respond, like the digital health platform that I'm working with specifically targets geriatric brains that are very vulnerable. And we are often in a position where we can't get informed consent, often because the patient's obtunded or delirious. And so we're grappling with that. And we're also grappling with, even if we use data acutely without consent in the near term to save a life or to save a brain, how do we interact with the patient afterwards and perhaps offer them that data, or give them some kind of user-centric control over that data? So that's one point. The second is many of them are not digital natives, and it's very difficult for them to actually understand this whole landscape. Does anybody else have a comment about specifically interacting with populations who may not understand the use of this data that they want to make?
No, but it's a really good point that happens a lot with that population, where you actually get delegation of authority for decisions about those individuals as well. And that's something that in some way, shape or form, we need to kind of think in that broader systems thinking of the healthcare XR ecosystem. How on earth do we manage for that and then their data and ownership and what on earth happens with that and consent, etc. That's a really, really kind of difficult situation as someone who's just had to deal with a parent who's sadly got dementia, etc. and stuff. And a scenario where three siblings were put in charge of making a decision and trying to deal with a bank to get anything done was an absolute nightmare. Trying to get three siblings to consent to data around healthcare could just be absolutely chaotic. And so that cross section of legal and then healthcare data and regulation stuff is going to be a real challenge, 100%.
I just wanted to add, I also chose a different thing. I mean, they're all important to some extent, but how that data is misused was possibly more important to me than actually the underlying algorithm that arrived at a particular solution, only because I am especially worried about all this digital exhaust and biometric exhaust that we are leaving in the world. Voice biometrics could be used to diagnose early dementia and things like that. So I'm especially concerned about the misuse of the data. Yes, and these issues are completely intertwined. David, could you bring us to the next swarm question?
Happy to. This also is our last question of the afternoon. And on this question, you are going to have some quantitative targets. We're really asking you to aim for the ones that you think is most representative of how prepared are healthcare systems for the changes in data and AI. So obviously these numbers are not precise, but give some thought to which do you think is the most representative? So I want to point out on this question in particular that the the split was primarily between 0% and 25%. We have other question method modalities in Swarm that would have allowed us to identify a much more precise number right away, but they take a little extra time. But I want to make sure that everybody is aware that what we were saying here was not necessarily that it was zero, an absolute number. And in fact, when we provide the follow-up data, we're actually able to analyze the collective input that was provided. So all those people pulling for 25 and 0% and really various gradients in between. And we'll be able to interpolate out a more precise number. But thank you very much. So Divya, that was the last of the swarm questions that we have prepared.
Thank you for that. And thanks for actually summarizing that for us really beautifully. Before I hand off the mic back to our chair, I actually wanted to invite Joe Morgan to speak. I know that you had some prepared comments, Joe. So do you want to go ahead and feel free to give a one-liner about yourself as well?
Sure. Yeah, I will. Do we have the slides prepared? I can share my screen or whatever you'd like to do. I have just.
You can share your screen.
Okay. All right. So just let me know if you can see that, and I'll put it into slide mode here. So this is me. I am a practicing anesthesiologist, and I founded a company in 2016 focusing on building extended reality solutions using various different constructs that have been found to be useful to help patients and providers. And so I just wanted to share a few comments and thoughts. This is kind of really at the confluence of a lot of things that are, very right up my alley in terms of, where I've spent the majority of my time over the past 7 or 8 years. So I just wanted to say first, I'm preaching the choir here, but how we start to think about extended reality in particular, and I tend to focus on the positive side. And we have to get to a benefit before there is potential drawbacks to protect against. I think, of course, we have to keep them in mind from stage one, and from ideation all the way through, and as well as part of the iteration and quality monitoring process as well. But really, I mean, extended reality is a huge promise for really enabling better and more distributed systems of care, and ultimately patients and providers being empowered to do so particularly within the United States. I can't really speak too intelligently about systems abroad, but certainly within the United States healthcare system, if you will, it's one where we all know that the administrative burden has increased tremendously, and provider burnout is real, and a lot of that really comes from, I think, three central things, three or four, and it's really control over how you practice, control over your life, and so forth. And I think a lot of that, both in terms of patients as well as providers, there's this sort of loss of agency, or at least a feeling of such. And I think that extended reality offers a tremendous amount of promise to correct the ship in terms of all of that. So just wanted to spend a couple minutes on one slide, and then I'll basically show some stuff that I'm working on, that our team has been working on in the XR and AI space. And really, there's three themes that I think are very prevalent in today's conversation, and certainly have been front and center for us as a company over the past 7 or 8 years. And the themes are safety, privacy, and enabled care. And just I'll speak about one example, sort of artificial intelligence technique, and really try to tie together several of the different things that we've been discussing today, to hopefully give a little more context, and provide some context in terms of how we think about things as clinicians. But the computer vision model that you see over there on the right side of the screen is actually a system that we developed in I think it was early 2020. And this is an edge system working on device, using a Pico Neo 2, and we were basically applying a you only look once model, YOLO, on device to identify objects using a bounding box. And the numbers you see there are confidence levels for the particular items. And really just a very simple example here, but I think the point here is that you have a cup and you have a sofa. Maybe it's 1:30 in the morning, and maybe you should lay down on that couch and not drink that cup of coffee. And so you could start to think about, as these technologies and capabilities become more ubiquitous, and frankly more omnipresent, how can we really use these things to help people, and to avoid disease? And I think that is a really profound and striking possibility in terms of just how these things are going to come about. And so the illustrative example I give there, I want to just stop for a second and basically say that these things are already ubiquitous. I think that the microphone array, the RGB camera, even Wi-Fi for that matter, are extremely powerful sensor arrays. And we were talking about heart rate earlier, for example. Fluctuations in the skin hue of somebody's face, for example, can give pretty accurate heart rate. There's even been experiments, really definitively showing changes in heart rate and EEG and so forth using Wi-Fi. And so these things are naturally going to become more passive, meaning that the user, if you will, or the person being sensed or monitored, really doesn't really have to be doing anything or actively participating in anything. And so this starts to get to, I think, really the critically important nature of the subject matter we're talking about today. And so just, cruising on down the line, I think speech to text and text to speech are obviously very useful, changing intonation, emotionality, and so forth. Recurrent neural networks are particularly useful for time series data. And in the context of extended reality, one could think about an experience, for example, as a vignette or a sequence of different things that could happen to the user or that the user could interact with as a function of time. Large language models I won't go into because everyone's being flooded with that all the time right now. And reinforcement learning, really, issuing rewards for essentially following a policy and iterating over that to achieve a certain result. Federated learning, I think we touched upon that, and it's a very useful technique for solving some of the problems that we're talking about today. And I think, we're really getting at the questions that are at the bottom there in terms of who has agency, who has autonomy. And that's really, I think, obviously emerging as a central theme. And so the next slide, I'm going to go into it's a quick 30-second video showing some of the stuff that we've been working on for over 2 years. And this is something that I actually started. It's very serendipitous that we were just talking about older folks, and I actually felt deeply inspired to make something like this after my mother passed away in August of 2020. She was had a rapidly progressive form of Alzheimer's and was placed into a nursing home. And before that happened, I did have a chance to actually give virtual reality to her. She always wanted to go back to Italy, and it was a wonderful thing. And so that inspired me to really work towards developing a system that would enable people to go where they wanted to go or do what they wanted to do, whether that was a real experience or place or whether that was an imagined place. And so this has been something we've been working on for a long time. And these questions that we're talking about today have been the overwhelming majority addressing these issues have been the overwhelming majority of the iceberg below the water with regards to this. And so with that, I'll just kind of go and show it. And basically, I'll let it kind of speak for itself. And this is just a little preview to kind of get an idea. But the most important point I want to emphasize here is that, this is not just something that's kind of put together. There are a lot of checks and there are a lot of elements here and redundancies to prevent doing harm or unintended consequences.
A majestic mountain vista with a colorful sky at sunset.
Is this correct?
Yes.
Taking you to your dream.
And so there's the majestic mountain vista that was just requested. And with that, thank you. And this has been a great talk. I'm actually, I have to confess, I'm coming off of 24-hour call, and I'm just so excited to have the opportunity to jump on this call with everyone. It's a great community, and this is really important work we're doing.
Joe is a fellow anesthesiologist who does 24-hour shifts. I really appreciate your being here. So I want to, by the way, there's been a really, really active chat going on that's emphasizing things like cost, energy, and inputs into cloud compute. Who bears the cost of that? Who should be keeper of data? And also the things that Joe just emphasized for us, which are how passive sensors in our built environment can be used to collect all kinds of biometric data that we never formally thought of as sensitive healthcare data. So I think this has been a rich discussion, but I feel like we've only just started. So I'd encourage you all to stay engaged with one another, engage with XRSI. Send in any of your comments if you have them, because we'll be putting them together in the Roundtable report. And with that, I actually wanted to pass off to my co-host, Richard.
Richard, if I could interject, just because I see that Natalia Kosmina has joined us.
Sorry, Julia. I
No,
didn't
that's
realize
okay.
that.
Couldn't have known. So you're following schedule, and we're adjusting as the tides change. Natalia, would you like to share your presentation?
Yes, super quick. I know I'm super out of schedule. I had literally fire. I was with you since 2 p.m. Perfect on time. I'm in Boston, by the way. Nice to meet you all. And at exactly 3:59, I had a fire alarm. What a coincidence. It didn't happen in the first, and we literally just got cleared. We did have a little accident, but everything is fine. It was just from chemical solution. So let me be super fast. I'm gonna be talking about, and just making sure that I will be on time, about a slightly different perspective. I believe that's what Julia told me. So I'm sorry if I actually missed someone already highlighting this perspective, but about research perspective for the XR. And definitely, we do a lot of, what is very different in the focus, because it's obviously a lot of prototypes, a lot of designs that are just not yet there. And specifically, this is just my disclosure slide. Thanks for all the companies who supported the work. But the big focus is, like, right now, think about yourselves. You all wear at least maybe one, if not more, smart devices like Oura rings. You have your smart watches that track your sleep. You might have even more, some smart earbuds, headphones, and we have a lot of like face masks, or some of the things that we mandatory need to wear in some spaces like hospitals, and they're all getting very close to our body. And with this, we have this opportunity to pick up these enhanced, sensing modalities like brain activity, skin conductivity. And this is a whole plethora, of course, of opportunities there. And it's very important to understand that, and I'm going to be just skipping through those slides and just sharing right then and there, that regardless of the opportunities which are there, like, we can have those sensors in ICUs, home support for LS, ASDs, and driving, and a lot of different setup. There is also no regulations whatsoever actually available for those. So just giving you an example, there's a lot of research in sleep, right? 1/3 of our time we spend sleeping. And imagine if your Alexa that you have in your bedroom, I hope you don't, but in case you do, and it's a great tool sometimes, right, to help you, to support your needs, for those of you who would actually speak and feel more comfortable speaking than typing. And it will tell you one night, oh, order this book for $99.99. Okay, you can cancel that order of Amazon next day, but what if it'll tell you, oh, your partner doesn't love you anymore. You need to divorce them. Just divorce them. And it's going to repeatedly, say that. So what do you think will happen in a month or two after this priming? And guess what? There is no regulations that this type of priming system that would influence in your most vulnerable state actually cannot be designed. And this doesn't even touch your body. Or obviously we saw a lot of push, with COVID. Hey, what if, in a couple of years, we will now need to show some cognitive paths to go through some spaces and environments, in our city. And of course, we did touch in the first part of the presentation that I actually was present on regulations and what happens when those prototypes are being actually taken off the market, with a very famous work of 19 brain implants were actually in use for 2+ years by obviously implanted in 19 patients, and then FDA revoked the license. And guess what happened? You needed to go back to those patients and take all of those implants out. People feel that they were violated. That's how they feel. But all of these examples, and I'm obviously just to accelerate and to be respectful of everyone's time, is for me touching beyond XR. XR is a shell, and we have now opportunity to enhance this shell, not only with generative AI, but also with this biosense and with this physiological sensing. And I can tell you, there is no regulation about that whatsoever. If you see some pops up about, you know, AI here and there, this one is fully wild west. And what is very important is that you know, our participants do ask where the data goes. They understand it. They actually, once they sign those clinical trial forms, they do understand that. And it's very hard to say, you know, back to them, this will be trained in this model, this goes on this server. No, this server will not be touched by this company. So I think there's basically two important things. So we should not try to be reactive. So patching the law and legislation when the systems are already being delivered. So you can say, oh, this is still pretty early on, this physiological sensing. RIN is nothing like a brain implant, but they're actually much closer than we think. Think about Neuralink and others, you know, that are really pushing it hard with a lot of amazing implications. So think about that. And obviously on the same side, think about the fact that, you know, being proactive in the technologies that maybe is just hitting the market or, you know, leaving the lab slowly, but will be fully redefining what we are as human, what type of data we have access, and what type of data everyone has access. Because, you know, just your diagnosis is however sensitive it is. Imagine if you will have access to what you're thinking about. We are not there yet, which is great news, and we are not there in the next 5 years or 10 years. But we are much closer to this than we have been 20 years ago. And this is what I want to encourage from the research perspective, because obviously a lot of labs do ring those bells, but, you know, reactivity is not going to help you. It's really more about being proactive. And thank you so much for your attention. I'm going to take down my slides, but here are my coordinates.
Thank you, Natalia, and I'm so glad you were able to make it to join us. And you bring up a really important point. I think I would really encourage everybody to continue these interactions, because as you can see, every single topic we touched, we barely scratched the surface. So with that, I actually want to pass it off to my co-moderator and this morning's co-host, Richard Price.
Thank you, Dr. Chanda, and thank you so much for facilitating that excellent subtopic discussion. And to all of the contributors in that session, we've learned a lot from that. So today has been a really wide-ranging discussion, and we've covered two key areas of XR and AI in healthcare. We covered the provider-patient relationship and the relationship between everyone working across the, as I called it, the healthcare ecosystem, so providers, patients, clinicians, and of course, private companies and insurers and all of the other parts that make up that rich ecosystem that we call healthcare. And then Dr. Chanda's just covered data privacy and patient agency in AI and enhancing the immersive healthcare and the role that we all have in respecting privacy and building trust in that AI. So it's been a really wide-ranging discussion, but I think at the heart of this really is around digital capability and patient literacy. Do patients understand what is meant by informed consent? Do they understand how their data are being used? And I suppose the thing that's really close to me, working in the global health space across lots of different countries with different populations, we really need to ensure equity of access to this technology. So I'm not just talking about upper income countries like we are in North America and in Europe, but across global health systems, we need to ensure data are used responsibly, and that trust is built between clinicians and the technology, and between patients and the technology. And what I mean by that responsibility is in making sure that we're not introducing biases based on the demographic, and using data that are equitable to ensure equitability to all patients at the point of care. And of course, there are going to be compromises necessary with all of this. The first swarm session, we had highlighted that accuracy often beats privacy. But they shouldn't jeopardize our rights, and they shouldn't jeopardize our ability to access that healthcare. And that's really key for me. But I think fundamental to all of the discussions today, and Dr. Chandra just covered this as well, the important thing is that this is the start of the conversation. We could have spent days talking about this, and I'm sure we all recognize that, and there's lots still to talk about. So we need to continue talking. We need to continue working together to build that trust, build that agency, and build that equity. So before I hand back to our chair, Julia, I just wanted to say a big thank you to all the team at XRSI who have been working hard behind the scenes today, to our sponsors, to our supporters, and to all those of you that have contributed today. And thank you for inviting the NHS and the UK National Health Service to be part of this really important discussion around healthcare immersive technologies. Julia, back to you.
Thank you, Richard, and thank you so much for leading this with me and organizing the whole process. So, as we conclude today's session on healthcare, our heartfelt thanks go to each of you who have contributed in your own way with your valuable insights. And it's working together that will actually develop new solutions that improve healthcare and transform how it's delivered. So one of the words that came up, or terms that came up in our discussion more than once, is shared responsibility. And shared responsibility model is easy to say, but hard to do. So we really need to consider what is possible with AI and immersive technologies to provide that better care while ensuring patient privacy and all stakeholder privacy, including the clinicians who are part of that data as well, as this data is powerful. So when we input both or inclusive of our bio data, which may be from XR technologies or peripherals, as Natalia has shared, so whether it be an EKG or brain data, as well as the spatial data that comes with XR technologies, and then also behavioral data. When those things converge and we use that to drive deep learning and transformer models, new abilities really do arise where we can diagnose more complex conditions that an individual may not be able to perceive. We can also detect things at an earlier stage when interventions can be effective. So the possibilities of actually improving care and training clinicians more effectively using both AI and immersive technology, as well as biodata, really opens up a new world that all of you are contributing to. So I see a lot of promise in what we're doing. But in this, as we move forward, in hand with that is developing ways to handle this data responsibly, so that a breach of that privacy does not lead to harms. So we extend our profound gratitude to our lead sponsor, Meta, for making this event possible, and to NHS England, our co-organizer, for their indispensable role in guiding today's discussions. As we close day 2 of Metaverse Safety Week, focusing on medical XR and immersive healthcare, we extend our heartfelt thanks to every participant for their insights, and our appreciation goes forward to all of you, as well as to David for leading our discussions with Unanimous AI and the support of Swarm Intelligence exercise, which hopefully made this a little bit more fun and interactive for each of you. Please share any relevant resources that you would like to disseminate to the group here at info@xrsi.org for a post-roundtable report. Looking forward, we still have the child safety and children's rights coming up tomorrow, followed by cybersecurity and data protection. And lastly, on December 14th, global policy and regulations. And that global policy and regulations is really the entity that's going to keep us in check as we develop from the developer stage to the provider stage. So we're inspired by today's discussions, advancing forward a metaverse that prioritizes patient care and ethical standards, Your engagement is crucial as we build a safer, more humane and digital world. As we conclude today's session on medical XR and immersive healthcare, we reflect on the transformative potential of AI in healthcare. The sensitivity of health data in immersive context requires delicate balance between privacy and patient empowerment. We discussed robust data protection, regulatory compliance, and strategies to enhance patient autonomy, and the evolving role of AI in the patient-provider relationship brings new dynamics demanding careful consideration and trust and ethics. This roundtable has laid the groundwork for anticipating the benefits and challenges of AI, guiding us toward a future where technology enhances patient care while upholding standards. So let us continue to innovate with responsibility and foresight, ensuring healthcare's future that's safe, equitable, and centered on human dignity. Thank you again, and please don't forget to join us tomorrow and the rest of these days for Metaverse Safety Week. Thank you. Right, and that concludes us. Thank you, everyone, for sticking through for the entirety of the session. It's like a marathon. I hope this was of great value to each of you. Right. Have a wonderful evening.
Thank you so much for hosting.
Thank you, Sylvia, for your contributions.
Thank you, Julia.
Thanks.
Thank you, Julia. Amazing job chairing. Thank you.
Likewise, Richard.
Thanks, everyone. Cheers.
Thank you, Richard. Thank you, everyone. I am just going to end the session for everyone. Thank you all for joining us.